Hi friends, good evening. I'm Dr. Ashutosh Gupta. We have had spoken in length about NIPT, right? And how this technology works. What are the limitations? What are the advantages? What are the disadvantages? How this could be false positive and negative, right? You're getting my point. I do have a lot of videos on this NIPT, right? And now today we will talk about the micro deletions that can be picked up, what is the sensitivity and how this NIPT can be used to identify some microdeletions and duplications in the fetus, right? So let us first identify what is the background risk. Background risk is 1 to 2%. That 1 to 2% out of 100, 1 to 2% of the babies they can have some sort of an some microscopic sort of an microdeletions and duplications, right? Then probably we do have those criteria by which we can identify depending upon the size and depending upon the size of that micro deletions and where they are being placed, right? Third thing is this: what is the general background frequency of identifying those micro deletions, whether they are associated with some other abnormalities or an ultrasound sort of an some soft markers on the ultrasound, like if we see some sort of a conotruncal malformation, then it is like this. Like if we see conotruncal malformation, or probably we do have some thymic hypoplasia, then it could be 22q. If we are having some issues regarding the nasal bone, then probably my target is 1p36. If we are identifying some conotruncal isolated, then probably William Brewer. And if I do in the family, then probably I'll do the Angelman's in the Prader-Willi, right? So depending upon the ultrasound, or reverse way around, those microdeletions, I'll just enumerate those microdeletions. Probably clinical microdeletions and duplications are something around 10. They do have those exclusive or sort of an very very specific some sort of an ultrasound findings that are very specific for to those microdeletions and duplications. So probably we can utilize all those clinical findings so as to zero down onto the microdeletions that probably is of our area of interest, and therefore how do we look around for, right? Let us first see all these things, and then we'll talk about how this NIPT works whenever we are suspecting some microdeletions in the background. So the microdeletions could be 22q. We can have 1p36. We can have triducat. We can have this Smith Magnus Miller Dicker. We can have 16p, and this is the complete list. But we can have 10 clinical relevant microdeletions. Right? How do we see to it? This could be NIPT, CMA, karyotype, and we can have a fish. The limitations are there. We can have confined placental mosaicism. We could have false positives and false negatives. And this is the chart showing the performance. And this is the limitations, that how do we look around for it. So there are some reasons for which this could be false positive. There could be some reasons for which this test could have a false negative. And once they turn out to be positive, how do you confirm the abnormal NIPT finding? Once the NIPT was being introduced, it was basically to see for Down syndrome, but as the technology is advanced, so probably this area has been expanded to see for common aneuploidies. Then probably came all the other chromosomes, and then it has been extended to those microdeletions and duplications first. Secondly, if we talk about common aneuploidies, we do have fetal fraction, which has got a threshold, right? So we talk about the common aneuploidies and microdeletions. So fetal fraction has to be greater than 4%, and then it works wonderfully well for the aneuploidies. But for microdeletions, they have to be greater than 10%, right? And the second thing is this: whenever we're talking about microdeletions, the length of that microdeletion has to be greater than something around 5 MB, right? It is a big microdeletion, or it is a big deletion that can be picked up by doing a normal karyotype. And if the deletion is that big, then only the sensitivity of the NIPT is really great of the NIPT to pick it up, the microdeletion, right? And many a times many times what happens is that the mother could be a carrier for that microdeletion, and the fetus is normal, and therefore since the fetal DNA gets mixed up with maternal DNA, and therefore the maternal deletion is being picked up, right? In two-thirds of the cases we've identified that this could be false positive even. And then we can have some sort of an reasons, like we can have vanishing, we can have confined placental mosaicism, and we can have a maternal deletion, so that might lead to a false positive. False negative is this, that probably you do have a fetal fraction which is less, and the sensitivity of the NIPT is not that great. The basically the deletion is less than 3 MB, and therefore the sensitivity of the NIPT to pick up those microdeletions falls drastically down. Right, so make it a point that probably whenever the NIPT has to be used for those microdeletions, the area or the microdeletion which is there in interest has to have a deletion greater than 5 megabase pairs, 5 MB, and that the fetal fraction has to be greater than 10%. So meaning thereby that many a times we identified that all these things, they cannot be all this basically prerequisite for this NIPT to work wonderfully well for microdeletions. They might not be fulfilled, and therefore the sensitivity, or it might even turn out to be, so two-thirds of the cases we've identified that they are false positives. Right, so it is always better to do the whenever we are suspecting some microdeletions, it is always better to do the invasive stuff, which is called as an amniocentesis, and look around for a CMA, because in the slides I've told you that the CMA works at the level of 10 to 100 kb. And if we talk about the common sort of a microdeletion which is 22q, so it is a big area of something around 5 MB, but probably you can have an interstitial deletion. It is not something that the whole area it is going to get deleted, right? Which would get picked up on an NIPT. But the thing is this, that probably we can have some interstitial deletion. This area is huge of 5 MB to 10 MB, but probably what can happen is this, that probably we can have some small deletions into that area that might get mixed up by, that can get missed and not being picked up by the NIPT, and therefore might turn out to be false negative. But the baby might be carrying those micro deletions. So if we talk about 22q microdeletion, and so meaning thereby that depending upon the varying length of the sort of a deletion, we can have some four different variable clinical varieties of deletions of the same area, depending upon the different length of the microdeletion that we are talking about, right? So make it a point that for common aneuploidies, NIPT works wonderfully well. The fetal fraction has to be greater than 4%. Whenever we are getting into the microdeletions, the fetal FF or fetal fraction has to be greater than 10%, and the baseline macrodeletion under interest has to have sort of a more than 5 megabase pairs deletions before we can even think of this NIPT picking up, right? So all these things, they have to be adjusted with the clinical scenario in hand. And once it turns out to be normal, it really doesn't rules out the back. It doesn't rules out. It could be false negative, and it doesn't rules out depending upon the technique and depending upon the deletion, depending upon the fetal fraction. So meaning thereby that it doesn't rules out the microdeletion in the background, even though the report turns out to be negative. And once it turns out to be positive, we've identified that in two-thirds of the cases, this could be maternal deletion being picked up by the NIPT, and therefore this could be false positive. So probably we should be mindful of the false positive and negatives whenever we are dealing with, whenever we are using the NIPT for microdeletions, right? So hope this is going to sort some sort of an confusion regarding the microdeletions and NIPT. Thank you very much for your patient listening.